Hi, in this succeeding discussion, we'll be talking about structural and obstructive bowel disorders. So our focus here will be your small intestine and your large intestine. Now, let's talk about your intestinal obstruction. So intestinal obstruction could be of two types. It could be partial or complete. The description whether it will be partial or complete is on the name itself. So when I talk about partial obstruction, okay, there is still a little passageway for the seepage to occur, for the fecal matter to pass through. Whereas in a complete obstruction, the fecal matter is not able to pass through. Now, let's talk about the types of obstruction. Other than being classified as partial or complete, it can also be classified as mechanical or functional. When I talk about mechanical, this talks about either intraluminal versus intramural or simply mural type of obstruction. So when I say intraluminal, it is within the intestinal lumen. Okay, the problem is within the lumen of your intestines. When I talk about intramural, the problem is within the walls. Okay, so for example, outside the intestines. If it is outside, it's referred to as extramural. Okay, outside the intestines, mechanical obstruction could be caused by adhesions. When I say adhesions, okay, the parts of the intestine are sticking to one another. Hernias. When I say hernias, just like your hiatal hernia, okay, intestinal hernia could also occur, meaning a part of your intestine went out of a muscle because of a muscle weakness. And then within intestines, okay, you might have problems such as tumors, okay, or your IBDs. Remember our discussion on inflammatory bowel diseases. And then obstruction of the intestinal lumen. Later on, we will see intussusception, which is the telescoping of your intestines. You will see volvulus, which is the twisting of your intestines, the presence of your foreign bodies, or the narrowing and strictures. Okay, so these are the possible obstruction on the intestinal lumen. So these are intraluminal. Okay, intraluminal reasons for mechanical obstruction. Now, okay, so this one is an example of your intussusception. Not an example, but this one shows what happens in intussusception. So, intussusception is defined as the telescoping, okay, of a part of intestine. So, what do we mean by telescoping? If you would look at this, okay, if this is the intestine or the small intestine, this is your ileocecal valve, and this is already part of your ascending colon, you can notice that a part of the small intestine was inserted, okay, to that of the large intestine. Okay, you refer to that one as the telescoping or intussusception. Okay, that does not only happen between the small intestine and the large intestine, but could also occur, okay, within the small intestine and within the large intestine. So if you would look at the example on your left, okay, a part of a small intestine was inserted, okay, to a part distal to it or proximal to it. Okay, so if you would look at the cross section, there is narrowing here because of telescoping. Okay, oftentimes this is caused by muscle weakness. Okay, we'll learn more about that later on. Then you have your volvulus of the colon. So I said on the volvulus, there is twisting of the colon. Okay, if you would look at this, they're citing an example, the sigmoid colon. So what happened is that the part of the sigmoid was twisted. So what happened on that part that twisted? Okay, food will not be able to pass through. Fecal matter or chyme will not be able to pass through. Hence, it would appear as an obstruction for that matter. Then we have functional. So when I talk about functional, this refers to inability of the intestine to propel contents along the bowel. Okay, so there is an inability for peristalsis. We refer to this condition as your paralytic ileus. In other words, the ileus, okay, or the small intestine is paralyzed. Okay, also sometimes referred to as adynamic ileus. There are several reasons for this. It could be because of neurologic or muscular impairment. One, it could be after a gastrointestinal surgery. Two, it could be because of tissue anoxia, lack of oxygen or absence of oxygen, or peritoneal irritation. Three, it can also be caused by decreased potassium levels or hypokalemia. It could also be because of depressant medications, such as your narcotics. It could also be because of your sympathetic medications, such as your antidiarrheal and anticholinergic. If you will recall, your antidiarrheal and anticholinergic works by slowing down the gastrointestinal system. So, if there is overdosage of your antidiarrheal or anticholinergic medications, the tendency is for your intestines not to move anymore. Condition, paralytic ileus. Then we have your spinal cord injury. So, if there is a damage on the spinal cord, a compression on the spinal cord because of injury, because of fracture, okay, there will B, no innervation going towards your small intestine. Hence, you will have a problem of functional obstruction. Okay, so usually when I talk about neurologic muscular problems, it's functional obstruction. These images here would show you the common reasons or common causes for your uh, bowel obstruction. So you have your strangulated hernias, the first picture. So as you can see, there is a protrusion of the organ or protrusion of the part of your intestine, okay, through a muscle, and then volvulus, which is the twisting, and then intussusception, which is the telescoping of your intestines. Another diagram would be this one. Okay, adhesions here is added. So as you can see in adhesions, there are parts of the intestine stick with one another. Okay, so that's why to remove adhesions, a procedure that is done is adhesiolysis, okay, which is the removal of your adhesions. The strangulation here is a specific type of your hernia. Okay, just the same as the strangulation that we have discussed in your hiatal hernia. So the principle is almost the same. As you can see, there is a decrease of blood flow due to the compression in the part where the hernia came out. Another diagram would be this one. Okay, adhesions here is added. So as you can see in adhesions, there are parts of the intestine stick with one another. Okay, so that's why to remove adhesions, a procedure that is done is adhesiolysis, okay, which is the removal of your adhesions. The strangulation here is a specific type of your hernia. Okay, just the same as the strangulation that we have discussed in your hiatal hernia. So the principle is almost the same. As you can see, there is a decrease of blood flow due to the compression in the part where the hernia came out. Now, let's talk about the pathophysiology of your bowel obstruction. So any obstruction in the intestinal lumen, in this case we are looking at the obstruction because of adhesion, would lead to fluid and gas accumulation. That accumulation of your fluid and gas occurs, of course, in the area which is proximal to the area of obstruction. Because of that, there is a tendency for bowel distension, meaning there is enlargement of our small intestine or large intestine, whatever is affected. Because of that bowel distension, there is an increase in intestinal fluid secretions. However, it cannot be absorbed properly by your small intestines because it is not passing through the entire small intestine for that matter. And because of that, there is a build-up of fluid along with your block lumen. Okay, so this is the build-up of your fluid. It's even blocked. Now, there is increase in peristalsis because your small intestine is thinking that I need to push this out. So increase in peristalsis is a compensation. Okay, this needs to be out. Because of that increase in peristalsis, there is also an increase in the distension on that damaged area. In the long run, okay, there will be decrease of venous return because of the compression on that area. And if there is a decrease in venous return, meaning the blood and the fluids are pooling on that part of the intestine which is distended, there will be a capillary fluid leak. Okay, the fluid from the small intestine would leak to the intestinal lumen, the peritoneal cavity, and even to the bowel wall. Your patient would manifest of signs and symptoms of edema. Okay, or in other words, your patient would have ascites. And because of that ascites, there will be an increased permeability towards bacteria. And that increase in permeability with the bacteria will lead to your peritonitis, which is of course a life-threatening condition and difficult to treat for our patients. Now, in the long run, if this process will not be halted, the intestines may burst, okay, because of over-distension. That would lead to the spilling of contents into the peritoneum. The peritoneum would again be inflamed. And the peritoneum is secreting a lot of fluid than the fluid it can reabsorb, aggravating your ascites and fluid accumulation on the abdomen. So what are the assessment findings? Immediately, you will notice distension. There will be an increase in bowel sounds, okay, and it's severe colicky abdominal pain in an attempt to increase peristalsis because you would want to move it out. Partial obstruction would manifest as diarrhea stools. Okay, this is what you call a seepage. Okay, meaning the liquid component of the stool is trying to seep through on that small part that is not obstructed. And then you will have fluid and electrolyte changes, okay, due to dehydration and then ascites. So with the fluid and the electrolyte imbalance, especially sodium and potassium, okay, you will have problems related to cardio and then neuro for that matter. Then vomiting. Okay, If it is bile stained, the tendency is that the obstruction is high up in the intestine. If it is fecal stained, the tendency is that the obstruction is in the ileum or in the lower colon. Then peritonitis. So you have board-like abdomen, and then later on the decrease of your bowel sounds. There will be impaired oxygenation because of the failure of the diaphragm to expand properly or to go down properly, to relax because of the ascitic fluid inside the abdomen. Then on X-ray, you will see increased fluid and gas in an obstructed bowel. Now let us focus on your small bowel obstruction. So small bowel obstruction, we're talking about small intestines here. Common causes are adhesions or bands of scar tissue. Then you'll have your hernia and then your neoplasms. So when I say neoplasms, this could be your tumors or your cancerous growth. Now, in small bowel obstruction, the manifestation would be abdominal distension. Then you would have crampy pain, which is colicky abdominal pain, which is usually the initial symptom. Again, for the vomiting, it may contain fecal matter if the obstruction is somewhere in the ileum. Reverse peristalsis occurs in complete obstruction. What do I mean by reverse peristalsis? So instead of the peristaltic movement to go down the GI tract, the tendency is for the food to be propelled or for the chyme to be propelled upwards. For that reason, your patient is having fecal matter on the vomitus. Then of course, signs of dehydration. Bowel sounds, burburigmy, your hyperactive bowel sounds or your burburigmy will be present on the early stage, whereas it will be absent on the late stage. Then there will be tenderness on palpation. Complications, hypovolemia, decreased fluid volume because your patient is not receiving adequate fluids. Imagine there is already a block in the small intestine, meaning the fluids could not go through the small intestine, could not even be absorbed in the large intestine, leading to hypovolemic shock, possible peritonitis, and then gangrene or necrosis or death of the tissues which are compressed because of the distension. Then in large bowel obstruction. For your large bowel obstruction, the common causes are volvulus, the twisting, cancer, diverticular disease we'll discuss later on, fecal impaction, hardened fecal material. Then you have your inflammatory disorders. So you have your ulcerative colitis, which is common for your large bowel. Manifestations, patient would have constipation and colicky abdominal pain. Still vomiting, distension is there. Bowel sounds tend to be high-pitched. There is localized tenderness. The shape of the stool seems to be altered. That is because that may be related to the narrowing of the passageway of the stool. Then there will be weakness, weight loss, and anorexia. Weakness, weight loss, anorexia is related to nutrient and fluid absorption. And then the loops of the large bowel may be visible through the abdominal wall. On palpation or even on inspection, you might be able to see some obvious signs of large bowel enlargement there, because of the obstruction. Diagnostic test, you have your X-ray. X-ray. Your X-ray will be able to visualize the gas. The black space in your X-ray is the gas. CT scan to get a 2D image. Your CBC would have more function on to evaluate whether there is presence of infection, whether there is presence of bleeding. Electrolytes, pay particular attention to sodium, potassium, and calcium. Your serum amylase may be increased in an attempt to digest all the food in the duodenum and jejunum. So you need to be careful because it might be stressing out your pancreas. Your ABG will be able to tell us if ever there is problem on oxygen and then carbon dioxide exchange. And then barium study. For your barium study, it is contraindicated if there is signs of perforations. However, there are references that would suggest that large bowel obstruction could still be evaluated using barium study. But if there are signs of perforation or you suspect perforation, barium study should not be carried out. Then, we have your X-ray here of intestinal obstruction. So as you can see, there is an obstruction on this part. As there is no continuity here of the black space anymore. So that signals an obstruction. Let's talk about small bowel obstruction. Going back to small bowel obstruction. So let's talk about the causes of your small bowel obstruction. Your hernia, then you have your intussusception, and then your volvulus. So for your hernia, it's the protrusion of your contents to the peritoneal cavity through a weakness in the abdominal wall. So remember, you have your abdominal muscles there. Once there is a weakness on the abdominal muscles and then intestines may protrude, okay, towards the peritoneal cavity, that is already hernia. Causes: muscle weakness and increased abdominal pressure. Recall the causes of your diaphragmatic hernia. It works the same way. Okay. Types: reducible, incarcerated, strangulated. When I say reducible, when we refer to reduction in med-surg, it means it can be returned to its original location. For example, if your patient will say, oh, there's something, okay, it's as if a part of my intestine goes down near my scrotum. And then my patient can say, anyway, I can push it up. That is a reducible hernia. When I talk about incarcerated hernia, it cannot be reduced. It cannot be pushed. Okay, that's why it's referred to as incarcerated. And when I talk about strangulated hernia, emergency, because the tissue is becoming ischemic already. Once there is ischemia of the tissues, they may result to necrosis. And once there is necrosis of the tissue, the necrosis may continue towards the distal end. Hence, need to be addressed. According to location, your hernia could be classified as inguinal, femoral, umbilical. Okay, it can also be incisional or ventral hernia. Now, try to differentiate and try to picture out each of this kind of hernia. So this one shows an example of your inguinal hernia. As you can see, it passed through the weakness of your abdominal muscles. Okay, so it occurs when the portion of the small intestine enters the inguinal canal. Then this one is a femoral hernia. As you may have noticed, the intestine has herniated, okay, causing a visible bulge here. Then this one is an umbilical hernia. Okay, so it has herniated through the umbilicus. So, what would you assess for a hernia? There will be a protrusion or lump over the herniated area, okay, while the patient is in supine position. If the patient would say there's pain, you would suspect incarceration already or strangulation. And signs and symptoms of obstruction will also be present. Medical management. So you have the use of your truss. I will show you truss later on. Then you have surgery, which is herniorrhaphy. Herniorrhaphy, rhaphy is repair, so repair of hernia for that matter. Okay, so this is an example of your hernia truss. So your truss is a supportive undergarment. The purpose of which is to keep the protruding tissue in place and relieve discomfort. Because oftentimes patients with hernia will just complain that they are uncomfortable. Okay, so to prevent the protrusion of the tissues here on the weakened muscle, what is being done is that the patient is advised to use a truss. Okay, so this truss will be able to keep the protruding tissue in place. Then, your patient would, this would make your patient feel comfortable temporarily. But take note, that does not treat the hernia. It is only a temporary measure. Oftentimes, there are patients who would use this if they will be in prolonged seating engagement. Let's say, for example, they will have a 12-hour trip by plane. Okay, oftentimes, they will use your truss. Now, when I say intussusception, telescoping of one portion of the bowel leading to an obstruction. Causes, it's idiopathic, usually for infants less than 1 year of age. However, for older children and adults, there is a term that we refer to as lead point. Okay, the lead point is the place of intestinal tissue, or the piece, of intestinal tissue that protrudes into the bowel lumen. Okay, so it's the lead. Okay, it's the one that protrudes through. This may be caused by a polyp. This may be caused by hyperplasia of your Peyer's patches. Your Peyer's patches are actually masses of lymphatic tissues. So if there is enlargement of your Peyer's patches, it may become the lead point. And then it may be caused by your Meckel diverticulum. Your Meckel diverticulum is a bulge in the lower part of the small intestine. Okay, this is usually congenital. And if your Meckel diverticulum is caught in the fecal stream, it may result to invagination. So when I say invagination, okay, this has nothing to do with the vagina, but this is the process of being turned inside out or folded back on itself to form a cavity or pouch. Again, when I say invagination, it is the process of being turned inside out or folded back to itself to form a cavity or pouch. So what are the assessment findings if your patient would have intussusception? Okay, still pain, vomiting, okay, may contain bile. Take note, bile would appear to be yellowish greenish, okay, usually greenish. Blood in the stool, okay, presence of blood in the stool, and then the stool may appear like a currant jelly stool. There's abdominal distension. Increase in temperature is evident if there is already signs of necrosis. peritoneal irritation. So patient would have rebound tenderness, would have guarding behavior, tachycardia, and then increase of your WBC. What will be our management for this patient? So we can use barium enema still for diagnostic studies if there is no lead point. And then surgery is done to repair the intussusception. So this is again an image of your small intestine with intussusception. Okay, so barium enema, as you can see, if the barium is traveling through the infected intestine or the affected intestine, you will see that there will be narrowing here. Okay, and then part of the barium would go here. So that will give us a sign that your patient is having intussusception. Next, cause of your small bowel obstruction is volvulus. Okay, so your volvulus is the swelling or the twisting, of the intestines upon itself. It may happen in the small intestine or sigmoid. Risk factors. This may be brought about by high residue diet, chronic constipation, habitual abuse of your laxative and enema, and then previous abdominal surgery. Assessment findings, signs and symptoms of abdominal obstructions. Then medical management, surgery. If it's not too late, okay, you can still remove the twist, but if it's too late, there's a tendency that the part needs to be cut and then anastomosis will be done for the healthy tissues. Okay, so this is an example of your volvulus. Adhesions, these are bands of scar tissues, okay, resulting to mechanical obstruction. What is the cause of this? In fact, it's the surgery. Okay, this scarring of tissues, which leads to adhesions, may in fact be because of the healing process that occurs inside the intestines. Okay, so what happens if there is adhesions? Okay, still, assessment findings would be the same of your bowel obstruction. Distension, increase of bowel sounds initially, then severe colicky abdominal pain. This is your adhesion. As you can see, it leads to closure or obstruction of your small intestine. Nursing management for intestinal obstruction. So what will we do if our patient has intestinal obstruction? First, we do what we refer to as gastric decompression. So when I say gastric decompression, the purpose of that is to relieve the stomach or is to relieve the intestines of distension. Okay, relieve distension. How do we do that? On that case, to do the decompression, we insert a nasogastric tube. Okay, and this nasogastric tube is usually attached to an intermittent suction. The purpose of the suction attached to your nasogastric tube is to drain the fluids, to drain the gases from the intestines. Okay, hence doing decompression or addressing the distension of your patient. In some cases, if it is not severe, we usually say attach NGT to drain. Okay, if you have noticed patients in the hospital wherein they have an NGT but then the NGT is just opened up to a certain tube or a container, okay, that is NGT attached to drain. Then, replacement of potassium, okay, especially if we're talking about a dynamic ileus. Okay, position changes, other than prevention of bed sores, your position changes could also trigger your peristalsis. Okay, we're also talking about rectal tube insertion. Okay, so rectal tube insertion for 20 to 30 minutes is done just to relieve the abdomen of distension. And then you have your fluid and electrolyte replacement. By the way, okay, you might be wondering why potassium have been mentioned there several times. Now, try to ask yourselves, what is the role of potassium when it comes to the movement or peristalsis? Is there a relationship between potassium and then the movement or peristalsis? Try to check on that. Then medications. So we may be giving cholinergics this time, okay? Because in intestinal obstruction, okay, our problem is that the GI tract is not moving. So if the obstruction is already relieved, we might need to move the GI tract. Okay, especially if we're talking about paralytic ileus, so we need to move the GI tract. So cholinergics, you have the classics, neostigmine and prostigmine. Okay, you talk about TRUS, which is for your hernia. And then for surgery, okay, there may be surgical decompression. There will be bowel resection, temporary or permanent colostomy, and then your herniorrhaphy. What are the possible nursing diagnoses for this patient? You'll have fluid volume deficit related to vomiting, decreased intestinal absorption of fluid, alteration of comfort, pain related to abdominal distension. Then you may have ineffective breathing pattern or impaired gas exchange related to ascites. So depending on the presenting signs and symptoms of your patient. The next topic that we will be discussing is your diverticular disease. Thank you very much for your attention on this one.